All right. Thank you all for joining us this afternoon. We're really lucky. We have Amy Graham with Stroudwater presenting for us today. She's passionate and really the go-to person regarding revenue cycle management. She's going to be talking about best practices. This is kind of our first webinar along the lines of revenue cycle management. And when Amy and I met, a few weeks ago to plan for this webinar, she asked, are there any particular areas that she should address? And I was like, no, let's do broad and really gauge from you guys what you want to hear. So, as always, this is as informal as we can be. And so if you have questions, if you have ideas, leaving here from today, if there are specific topics that you want to see addressed or go deeper into, please let us know, because we want to provide those resources and get that expertise to you. So with that said, I'll turn it over to Amy. But again, if you have any questions, you can unmute your own lines. And also I'll be watching the chat to see if there's any questions come in.
Super. Hey, thanks, Laura. I appreciate that. And as she said, I do really enjoy talking about revenue cycle. I'm probably one of the strange people out there. I was sharing with her and the people that were on the call earlier that my husband, he looks at me and he's like, Amy, I love you dearly, but no one looks to talk about revenue cycle for an hour. So I really do appreciate the time that you've given me today just to talk to you about it. And to say thank you for, just giving me this time in your day. And hopefully I'll make it informative for you and give you some just best practices that you can talk about. And really, when we talk about revenue cycle, the first thing I like to do is let's set the table and say, okay, what is revenue cycle? Because it's, some of you may refer to it as billing or coding. However, it's really more robust than that. And there are a lot of different functions and activities that take place with a revenue cycle. And so what I wanted to do is just spend some time today to get us all sitting around the same table and talking about this, so that then that way when you go, oh, I really have an issue with this, let's talk about that. And that you realize that, oh, that is part of revenue cycle, isn't it? And then in other instances, you may go, well, if we would just fix this upstream in the revenue cycle process, it would help me out downstream. And so when looking at it, what we have done is to show that it's a multifaceted process, that you actually have a claim life cycle that happens where you have the pre-visit or the front end transactions, transaction processing, and back end. And so like the front end, that's where you have the pre-visit information that comes in for your clinic, where you're scheduling and registration, insurance verification, just prior authorizations and appointment reminders, things that happen before the patients ever show up. And then you have that activity where the patient comes in, they're there for the visit, they've checked in, it's your first opportunity to collect on any copays and deductibles that are there, make patient payment arrangements, encounter documentation, coding and charge capture. Then you get into the transaction processing where it really becomes transactional. The patient's left, but you take that information from the charge and you've got the charge entry, claim scrubbing, pre-adjudication, claim submission. There's a difference between claim scrubbing and claim submission. We're just, one of them is getting it ready to go, and then the other one is where you actually send it off to the payer. And then EDI management, that information, that electronic information that's being transmitted back and forth. And then from there, you have inbound processing. That's where the mail is coming in, scanning and indexing of information, your bank deposits, ERA, EFT payment processing, payment posting, and then revenue allocation. And then finally, you get to the area that a lot of people think of when they refer to revenue cycle, and that's the back end side of the piece. And that back end side of the piece talks about claim status, denials management, appeals and resolution, patient statements, collection letters, patient refunds, small balance write-offs, and the collections process, how you are sending claims out, what they come back, what that looks like. And then I say, but wait a minute. Revenue cycle is actually more than that. It's bookended by pre-claim activities and analytic activities. And the pre-claim activities are things like contract negotiation, provider credentialing, EDI enrollment, banking setup, CDM creation, and price transparency. And then on the back end with or then at the other end of the bookend or the analytics side with cash collections, where you're watching your no-show rates, your total days in AR, both at gross and net, any payer denial rates, clean claims rates, how many claims do you actually get out the door that no one had to touch, and then rejection analysis and cost to collect. And so if you think about activities that occur in each one of these stages impacts all of the downstream stages. And then the analytics piece is how you can watch that and monitor these processes. And so then all of that, though, has some revenue cycle management support, things that people don't think of when they look at revenue cycle, but they really are related to it. Things like month end closing, that if you don't have a revenue cycle report, makes it pretty hard to close the month. Cost reporting, the information and activities that are captured in the revenue cycle processes do indeed impact the cost report. Compliance, if you think about the coding activities and what transpires, what that looks like, performance management, and then IT and quality. And so these are the foundational functions that work interchangeably with revenue cycle management, and they are supporting each other. And so today, what I really wanted to do is to just start at the beginning and look at what are the pre-claim activities and focus on those. Because if these aren't set up correctly, you really will see the impact of that downstream. And so the first thing I talk about is a contract negotiation. So this starts before the first claim, before the first patient comes in the door. You're talking to your payers about what you want to pay, they are going to pay you for the services that you're providing. And then the more educated your patient will be, they will drive this pricing with contract negotiation. So when looking at contract negotiations, one of the things we want to ask is, do you have copies of the agreements? And when I say copies of all the agreements, I mean all the pages. Do you have all of the amendments? Sometimes agreements were signed in 2018 and then they've been amended 3 times since then because every year it gets amended. Then the fee schedules change. Do you have this information? Because if you don't understand if you have this information or not, then you don't know if you are getting paid correctly. So when thinking about it, do you have that information? And then when you look at that information and get it, what you want to make sure of is that you're paying attention to special clauses that are in that contract. Clauses like a lesser of payment clause. And what do I mean by lesser of? It's like when an insurance plan is going to pay you the lesser of the fee schedule or your charge amount. Sometimes they may say, we're going to pay you Medicare rates, the lesser of the Medicare rates and what your fee schedule is. And if your prices are priced below the Medicare fee schedule, then you're actually leaving payments on the table for these insurance plans. And then sometimes you've got price change notifications in there. How far in advance do you have to let the insurance company know that you are making changes to your prices? Do you have to let them know or not at all? One of the things to think about too are unlisted CPT codes. How are they addressed? When we think back to 2020, when no one had on their CDM, I'm pretty sure no one had a COVID test out there as part of their CDM. And so if that was listed in your contract as unlisted services will not be paid, then you wouldn't be paid for those processes. Or if it could be that unlisted charges are paid at unlisted CPT codes are paid at charges, 100% of charges, then you could get paid for those services. So those are things that you want to make sure of, that when you get copies of your agreement, that you are paying attention to those special clauses and how those things are considered. And then if the contract is silent to those, what does that mean? And how hard is it, to work with your payers to make sure that they are paying you the way for the services that you provided in a reasonable manner? And then the final thing to think about when looking at contract negotiations is talking about timely filing deadlines versus payment windows. Now, I'm going to spend a little bit of time here. I'm going to just rest on this one for a minute to just give you an example. So, if you have a claim, so say the contract says that your timely filing deadline is 90 days, but your payment window is 120 days. That means that you must get a clean claim out the door to the insurance company within 90 days. And that clean claim means that, you've got all your ducks in a row, all the appropriate boxes are filled out, the information is complete, and then you have to have it filed in 90 days. But then at 120 days, which is when your contract says the insurance has to pay you, they pay you, but they actually send you a denial that says unable to identify insured. What has happened then is that it's not a clean claim that has gone out the door, and you have lost the opportunity for your revenue cycle team to go back and get a payment on that claim. It couldn't even be included as an appeal because they've not adjudicated on it. They've just told you, we can't find the information. So you want to make sure that when you have your contracts and you are negotiating these contracts, that you are negotiating a payment window that happens before the timely filing deadline, to at least give that back end process an opportunity to correct any errors that may have happened earlier, or just there are times that the insurance company doesn't receive all of the appropriate information that we sent through on that electronic file. And then you want to make sure that payments, that it's specified that you're going to get paid in a certain amount of days. Then that way, you know that if they've told you that they're going to pay you within 120 days, and your timely filing deadline is at 180 days, that at 90 days, you have your team going out there and looking at these claims to really dig into it, because your contract has said they're going to pay you at 120 days. And so you want to be proactively going after them to make sure that that claim is on file, so that at 120 days, you have received that payment. Now, going on to payer contracting and contract negotiations. One of the things I like to share with people is that increases to your gross charges do not always fall to the bottom line. A lot of us know that, we can increase our gross charges all I want, but if they're only going to pay us, at what their fee schedule is, then that's what they're going to do. So you want to look at, when you're walking into a contract negotiation, that you are making sure to model out the projected impact of the CDM price changes by payer, that you understand what are those changes going to be. And as we talked about before, payer contracts contain reimbursement methodology language that, could trigger some lesser of clauses in contracts. It could have limits to annual insurance increases in prices, and then just how excluded services should be covered. And then talking about renegotiating the existing contract. When I talk to people about this topic, I like to share with them, it's like we never knew when we took algebra that we would actually use algebra in real life. But sometimes that's what you're doing when you think about renegotiating your existing contract. That you can say, you know what? If I reduce these charges, then I can get a higher percent of reimbursement. And so you want to, make sure that you're coming out equal, that you're solving for X, to make sure that you're not taking a haircut, but you're actually getting your insurance company to pay you at a higher rate. Because if you reduce them on certain volume procedures, you might get paid more on those procedures that you do less frequently. And so at the end of the day, that you are really capitalizing on that and looking at new ways to negotiate the contract, that you don't always have to walk into a contract and say, yeah, we're going to take a haircut this year. We're not, they're not going to pay us anymore, and go into it with that view. You can go in and say, okay, we'll take a haircut on these, but we want to have hair extensions on this other one, and look and see how that works out for your facility. Now, The next item on here, I've really grouped these three together: provider credentialing, EDI, ERA enrollment, and banking setup. And this is one that I like to talk to administrators about because, they're looking at bringing on a new provider and they think, oh, well, when we do the providers, we just have to do the provider just gets hired and we do a credentialing and boom, they're on board and we can bill for life is grand and they can go to work immediately. But really, I like to remind them that at the point at which the provider is hired, they need to start the revenue cycle process. That there are some payers out there that it takes 90 to 180 days to get the information through the payer and get that new physician hired. And so, one of the things I like to ask people is how many people internal to your facility are included in this process? Are the same people who are doing the hiring and bringing on new physicians, do they understand how many steps it takes to get that provider enrolled? And so when looking at the sooner revenue cycle finds out about it and that communication is happening, then the sooner you can start that payer enrollment process. And I will tell you, I've worked with small organizations, 25-bed facilities, and I've worked with one of the largest organizations in the world, in the top Fortune 10 companies doing accounts receivable for them. And what I will tell you is, it doesn't matter how large or how small your company is, it's still going to take you between 90 and 180 days to get enrolled with your payer. And then once you get enrolled with the payer, you have to do an EDI enrollment and banking setup so that you make sure that the payments for the services rendered are indeed making it to your bank account. And so when you think about bringing on new physicians, my recommendation is that until, as soon as you can find out that you are working with a physician and they have signed the contract that they're going to come to work with you, then you need to be involved in that credentialing process and so that you can enroll them with the payer and get your EDI banking set up. Because until you get it through that entire process, you will not be paid for the services that you're providing. And so you don't want them providing services in March, knowing that you're not going to get a payment until September or October because of the delay that it will take to get it through the payer. So the sooner you can get involved in that process and get the teams working together on that, knowing what the it's not the same documentation. It's very similar, that they still have to have the credentialing and the payers might want to see a copy of their license and things like that. But then the payer is going to have their own forms that have to get enrolled. And a lot of times you have to get the Medicare and Medicaid enrollment before the other payers will let them be signed up. So it's a lot of domino effect to making sure that you get those providers enrolled, and then you get them onboarded, you get them hired, and then enrolled with the payers so that on day one they can start receiving payments for the services. And then the next item we talk about is your Chargemaster. And one of the things I ask is, when is the last time you took a good look at your charges and your Chargemaster? Is it something that you set it up in the beginning when you first opened the door and, no one's really ever gone back and looked at it again to say, well, we keep adding to it, but, maybe we need to go back and look at some of the services that aren't out there. Now, when we talk about a Chargemaster, your Chargemaster is actually comprised, it starts off with three key elements. The first one being a CPT HCPCS code, a revenue code is the second one, and the price is the third item. Now, the CPT HCPCS code, this is where services that are provided are translated into codes that are used for billing. These are separate and distinct from ICD-10 codes. ICD-10 codes tell what the condition was of the patient that they were treated for, and these are actually from medical records. But the CPT code provides to the insurance company the services that were provided. And your CPT codes are established by the AMA. And HCPCS codes are codes that are established by CMS for services related to Medicare patients. And so those items are contained in your Chargemaster. Then you have a revenue code. This is where the services were provided. Typically for an RHC, your revenue code is going to be a 052 with an X being the to be the number to specify where the information is, but it could be an 0521 and things like that to just show where the services were provided in a hospital setting. These revenue codes could be like a 300 for laboratory services, but then you want to get a little more detailed when it's a histology service, that it may be a 310 revenue code that goes along with the CPT HCPCS code. But there is a correlation between the CPT and the revenue codes. And then the final item is the price. This is the charge for the procedure that was performed. So when thinking about the price does not always equal cost. Price is the fee that you are charging for the service. And when looking at your Chargemaster, there are 4 key areas that you want to think about and look at. The first key area is where you are missing a CPT HCPCS code. Do you have records within your Chargemaster where there are no CPT HCPCS codes? And why is it? Are those supply type items that don't have an assigned code? Or are those areas that it really was a test, a colonoscopy, for example, that doesn't have that 45378 attached to it? And so if it is a service that needs to have a CPT code applied to it, then chances are there's someone within your front end claims processing that is capturing all of those and manually having to enter the information. Where if you just went back to your Chargemaster and added the information, it prevents or it eliminates that manual intervention that happens later in the claim life cycle. Another area I talk about is below Medicare fee schedule. Just in looking at the Medicare fee schedule, what is the price that's assigned to the CPT HCPCS code, and is it below the CMS rate? Now, I recognize that you may or may not be paid according to the CMS fee schedule. However, it is the one fee schedule that is published out there on a consistent basis. It's been published for many years now, and it is seen as the industry standard of a fee schedule that people base their pricing off of. And so if your payers are paying a percent of charges, then you would want to look and see, am I at least getting paid what Medicare would pay me for these percent of charges? And if not, what do we need to do to increase up to that Medicare fee schedule? Now, some of you may be limited by constraints within your community that you don't want to be overpricing on certain services. But when you look at Medicare, typically Medicare is that baseline by which other fees are placed. And so you can look at them and say, if we structure it this way, then the copay for the patient would be the same amount of copay that it would be if they were a Medicare patient receiving these services at a PPS hospital. And then another area to look at are invalid CPT codes and HCPCS codes. What this is every year the AMA and CMS go into their files and they say these CPT codes are deleted. They've been replaced with these other CPT codes. Like, for example, at the beginning of the year, we had a lot of changes that occurred to the E&M codes that are being used. And so the standard one level E&M code that was out there is now an invalid CPT code because it's been replaced by other codes. And so what you want to do is to make sure that you have looked at your Chargemaster and removed any invalid CPT or HCPCS codes that are out there. Because if you don't change them, then chances are they're going to get caught in that claim scrubber that we talked about before, or it might be caught in a claim editor prior to the claim scrubber, or in worst case scenario, the claim goes all the way through the process, it makes it to the payer, it never gets rejected, but then what happens is it gets denied, and the services are denied for an invalid CPT code. And so you've lost the opportunity to collect on it because you billed for an invalid CPT code. And they haven't lost the total opportunity, but if you don't have someone actively managing those denials that come from the payer, they could be overlooked. And so by making sure that you don't have any invalid CPT codes in your Chargemaster, that way you are preventing someone choosing that code and having it sent through only to receive a denial and not get paid for those services. And then the final fourth key area to look at are same CPT HCPCS codes that are out there within your Chargemaster at multiple prices. And if you're associated with a critical access hospital, then what you want to do is to make sure that your pricing, that if you have different prices in the system from what they have established, that you understand why. It could be that you charge $50 for a complete metabolic profile at the clinic, but you only charge $40 for it at the hospital. And that difference could be because you actually have to drive the test to the hospital and have it run. So there's the cost of the transportation. So that is a defensible strategy. But if you're in the same building with your hospital or relatively close to it and you don't have that cost and it's just the same machinery that's providing it, then you need to understand why there is a difference in price and perhaps come up with a defensible strategy for it or pricing it at consistent pricing. And so you want to make sure that you are looking at your CPT codes that have multiple prices out there, because I can tell you from experience that the patient is going to pick up the phone and call you because they would just say, well, if I'd known I could go in a different door and save $10, I would have walked in that door. Those are the phone calls that you're going to get. You're not going to get the call for, hey, you charged me less than I thought I should get charged. You're going to, have that patient that's going to come in, and that's going to be the issue that you deal with for the day instead of having to deal with, the exceptions that are falling out, not the issues that you could have prevented by looking at your Chargemaster. And so when looking at your Chargemaster, there are some key questions that you need to ask. One of them being a defensible pricing strategy. Does your hospital, your clinic, have a strategy established for pricing? And is this strategy defensible? As we were talking about before, that you want to make sure that if prices are different between the hospital and the clinic, that you can defend why there is a difference in the pricing. And if there isn't really a reason to have that difference, that you are pricing them consistently. And then what you want to ask yourself about a full Chargemaster review is, when was the last time your entire hospital Chargemaster or your clinic Chargemaster was reviewed? And how have you looked at deleted codes going out there? And it's a cumulative effect. They don't delete it one year and reestablish it the next year. They leave the codes deleted out there and replace them with new ones. And then a CDM maintenance. Do you have an ongoing policy for establishing new procedures that engages both operations and revenue cycle? And I know we talk about revenue cycle here, but there are times that you need to get your clinic team involved and help them, have them help you in establishing the prices and the procedures that are needed. Because typically your radiology manager is going to understand the charges, the CPT codes that are associated with the services that they provide. Or if they're not familiar with them, you can pull out a CDM manual, and in looking at, not CDM, a CPT manual, and when looking at that CPT manual, they will help you distinguish between, say, an MRI with contrast and an MRI without contrast. That may be a simple example, but they can help relay to you what the differences in those two procedures are, because they are the one performing the tests and you are the one sending the claim out the door. And so you would work together, not just in a silo, but together on this. And then it makes for a more engaged discussion and a greater buy-in for this information. And then when looking at it, one of the things I did want to cover as well is pricing transparency. That pricing transparency works hand in hand with the above activities. That now what's happening is that information is being posted. So with pricing transparency, CMS came out with a ruling that went into effect on January 1st of this year. And what it says is that there are 300 shoppable services that must be presented on a hospital's website. And you may say, well, I'm not a hospital, I'm just a clinic. But if your charges are billed within or underneath your hospital's tax ID number, then your services need to be included in your shoppable services and pricing transparency. And so it's required that you do an annual maintenance of them, that it's as simple as just putting a date to say last time updated was August 23rd, 2021, August 24th, 2021. You updated the information. That meets the requirement for CMS. But if you don't have a date on your file to show when the last time it was reviewed and updated, then they don't know, and they cannot tell. It'll be in future years. They couldn't tell if you did it in 2021 or 2022. And then you also want to make sure that you do a charge review, that any changes in your standard charges are reflected on your pricing transparency and shoppable services that are out there. Any changes with negotiated rates or any ancillary services, whether they're new or revised. And then, as I was talking about before with the shoppable services, what this is for shoppable services, these are items that are non-urgent in nature, where people can look ahead of time to see where the lowest cost, highest quality provider is. And it could be that you see that your market has a need and you want to create a marketing strategy through your shoppable services and explain to your community, hey, look, come to us. We offer a colonoscopy. It's it's say $850 at our hospital or at our clinic, and we provide the same services. It's a great quality. Look, we have a 5-star rating on CMS. This is where we need to be. And come to us and have the services done. Don't get in your car and drive to Oklahoma City and have it done at the big, for-profit hospital. You can stay in the community. We will meet your need here. And just what does that look like? And then to also look at deleted services. If there was a group of services that you would have provided in the past that you decided there was just not a market need for it, so you're no longer providing those services, to make sure those services are removed from the listing of the 300 shoppable services. And then I did want to just show that there's some interdependencies between shoppable services, CDM pricing, cost reporting, and payer contracts. That with the critical access hospitals that you are connected to, these functions are all interconnected, and that changing one will impact the other. That when you change prices on your CDM, that's going to impact the revenue that is reported on the cost report. It will impact payer contracts, especially if they're a fee for service. And then you want to make sure that your shoppable services are updated. And so I tell people that there are 4 lanes on this highway and they're all interconnected, and that the circle, you don't want to make it an oval. You want to make sure that it stays a circle, or we could call it a roundabout in our highway, that we're driving down the road and we hit the roundabout. You just want to make sure it stays around and it doesn't get off track and get out of shape. And then looking at that, then coming back to just our revenue cycle activities, that gets us through just to the pre-claim activities. And we trust that these best practices will help you improve your processes, even if it's just to help everyone recognize that these are all of the activities that are included in revenue cycle management and are just interdependent upon one another. And that if you do improvements in the beginning stages, that it leads to efficiencies through the end. And so with that, I'm going to turn it back over to you, Laura, just to see if anyone has any questions that may have come through, or if you want to open up for any questions, I'm here to answer it for you.
Well, thank you, Amy. We haven't received any questions via the chat yet, but we have quite a few folks on the line. So if you guys have questions, please feel free to, shout them out or type them in the chat. Or if there's anything more specific that you want to hear, please let us know.
And I'm going to go back a page too, just to leave this slide out here to give you some information on it. And I will tell you, a common question that I do receive is just, where to start. How do I dig into this? And I will tell you that, it could start as easily as just looking at, going back to your CDM. What does your CDM look like? And what are the things that need to be fixed? And it could be that you start talking, you look at your denials and you say, okay, what denials am I getting for services that are deleted CPT codes? And then by fixing those denials for the deleted CPT codes leads you back to the CDM creation and how it was established and set up.
All right. Do we have any questions, or I want to know more topics?
Well, Laura, I have put my information here for everyone that if you'd like to get in touch with me just to take your questions offline, that's fine as well. And then I will send you this PowerPoint deck so that you can share it with the participants. And then that way, share it with your team, or if you later get to thinking about it, be like, oh, I'd really like to know more about this. I am available. And as I shared, just really enjoy talking about this and don't mind answering anybody's questions that you may have.
Well, that's perfect. Thank you. Yes, we will be sending this out. I am recording this, and we will get this uploaded to our YouTube channel. So I know many folks are swamped at the moment, and we covered some really good stuff. And so as you move through this, talk with your team. If you have any questions, or, hey, I want to know more about this, please let us know. We'd love to have another webinar because if you have the question, odds are your peers in other facilities do as well. And thank you, Amy, for your time.
Thank you.
Have a great rest of your day.